This PowerPoint will review the patient with aortic stenosis, some of the hemodynamic and structural considerations, especially as you're caring for them while they're in the hospital, and then we'll specifically look at pre and post transcatheter aortic valve replacement care when they come to the CVU for their procedure day. So just a basic review of anatomy. As we know, 4 chambers, 4 valves. As we trace the blood through the heart, goes to the right side, up into the lungs to be oxygenated down to the left side. The left ventricle is responsible for pumping the blood through that aortic valve out to the rest of the body. On the right-hand side of your screen, you can see an example of what the aortic valve should look like as a normal healthy aortic valve, and then what it begins to look like as a stenotic valve. The healthy valve, as the left ventricle pumps, those leaflets should open wide up and allow for the blood to flow freely out into the aorta and out to the rest of the body. Over time, when it develops stenosis or calcium, it has a much harder time opening. Those leaflets don't get out of the way, and the left ventricle has to work much harder to get the same amount of cardiac output out to the rest of the body. Aortic stenosis is actually the 3rd most common form of heart disease after coronary artery disease and hypertension, and it actually becomes more prevalent as patients age. So you'll see goes from 2.5% at 75 years to 8.1% at 85 years. As our patient population gets older, you may actually see these patients come into the hospital with some of their symptoms of valvular heart disease, or when we bring them in for their procedure. Their risk factors are shared with atherosclerosis. So the same things we look for with coronary artery disease, including hypertension, high lipids, diabetes, smoking, it shares that with aortic stenosis. Unfortunately, there's no medication to reverse it or stop the disease progression. So as these patients get older, we see more and more prevalence of this disease, and then have expanded options now for how we can treat that disease. This slide is just to show you that kind of the natural progression of what it looks like if you were to look straight onto that aortic valve and see the 3 leaflets and how they open wide up. That area is what we call the valve area that we're measuring to see how wide those leaflets are opening. So you can see as the stenosis becomes severe, how narrow that valve opening becomes. Typically in the progression of aortic stenosis, they've had a murmur that was detected by primary care or cardiologist that they've been watching over time. And we watch that echo criteria with valve area and gradients and velocity. And then we also talk with the patients about any possible symptoms that they may be having. Typical symptoms of aortic stenosis when it becomes severe tend to be dyspnea, fatigue. They can have chest pain, they can have lightheadedness, dizziness, and even pass out, and symptoms of heart failure. Often, if you're going to see them in the hospital prior to us bringing them in for their TAVR, they likely are being admitted with valvular heart failure issues, so fluid volume overload, shortness of breath. Usually when I see them in the office, they are telling me that they just are running out of steam earlier, they can't do the things that they used to be able to do. They oftentimes will just say, oh, I just felt like I was getting older. I thought this was pretty typical, but then on exam when they've gone to their primary doctor, they hear a murmur, they get an echocardiogram, and sure enough, they have this aortic stenosis that has progressed to severe. On this slide, the slide on the left, it was developed many, many years ago. However, it shows a depiction of how quickly, once symptoms develop, the mortality goes way up. So the life expectancy goes down once you start having symptoms of aortic stenosis, particularly heart failure symptoms. And just to kind of put it into perspective, it actually has a worse prognosis than many metastatic cancers. So if you have severe inoperable aortic stenosis, you actually have a worse 5-year survival than lung cancer, colorectal cancer, breast cancer, ovarian cancer, and prostate cancer. So it is more serious than we often think about, and it is a life-ending disease if it progresses. These just give you 2 examples of the aortic stenosis murmur if you'd like to listen to those. So let's talk a bit about structural and hemodynamic considerations when this valve becomes so stenotic. The progressive thickening, the calcification, and it leads to restriction and valve obstruction. So as that left ventricle is trying to promote the same amount of cardiac output through that tight valve, it leads to increased afterload, left ventricular hypertrophy, can eventually lead to decompensation and symptom development, heart failure, and death. So you can see in the picture on the right-hand side of your screen how thick that ventricle gets. So initially, it gets the ventricle gets thick. It is able to produce the same amount of cardiac output. Unfortunately, when it gets thick, it also decreases the chamber size, so the stroke volume, and then it can actually start to weaken the heart and start to have those symptoms of dyspnea, heart failure, and then, like we said, eventually, if nothing is done about it, then it will lead to death. So just some hemodynamic considerations for your patients with severe to critical AS. That valve is fixed. It is a fixed afterload, and they have a fixed cardiac output. So patients who have critical illness, hypotension, decreased preload, they cannot then generate enough cardiac output through that valve. So it's fixed. So you have to be careful with the diuresis. You have to be careful with blood pressure management. That stenotic aortic valve, it results in buildup of pressure inside the left ventricle, and then comparably a lower pressure in the aortic root. So when we're checking gradients, we're looking at the pressure in the LV, we're looking at the pressure in the AO, and we're taking the difference between the two. So anything with a gradient over 40 is considered severe. Your ostia of your coronary arteries are past the aortic valve, so they're on the other side of where that fixed valve is, where that fixed cardiac output. So if you have low blood pressure, if you have low preload, then it results in low coronary perfusion pressure, which, if your coronaries are not perfusing, then leaves your left ventricle susceptible to ischemia, which then reduces cardiac output, and it just becomes a cycle. The other thing is that when you have systemic hypotension, obviously you have reduced perfusing pressure and reduced coronary perfusion, but then you also have tachycardia as a compensation. And so the excessive tachycardia increases your myocardial oxygen demand, and then with the low coronary perfusion pressure and the increased heart rate, then they both can contribute just to this cycle of ischemia and cardiogenic shock. So you can very quickly get into trouble if you don't manage their blood pressure and preload with patients who have severe to critical AS. So just for your bullet points, avoid hypotension, avoid excessive tachycardia, maintain sinus rhythm, they need that atrial kick, optimize their preload, and then treat hypotension aggressively. So the vasopressor of choice would be phenylephrine. You can also, as a secondary, use Levophed, but Neo, as a pure alpha-1 agonist, will increase their diastolic blood pressure. So your coronary arteries are filled during diastole. So if you can increase perfusion pressure, increase your diastolic blood pressure, then you will increase and improve your coronary perfusion. A side effect of Neo is actually reflex bradycardia, which actually could be beneficial if you have some reflex tachycardia or you have some tachycardia with your patient. Then the reflex bradycardia actually could be a desired effect. We do want to avoid epinephrine because it will promote tachycardia, increase myocardial oxygen demand, and we don't need to promote that cycle if we're in trouble. So let's say we've identified a patient with severe to critical aortic stenosis. We know that they're having symptoms. Then how do we decide what is the best treatment for them? So the only definitive treatment for this disease is for a valve replacement, either by surgery or by this transcatheter approach. That doesn't mean that every patient gets a valve replacement. So we put them through a very thorough assessment. We look at overall function, frailty, comorbidities, and any limiting factors. Now, age does not have to be a limiting factor. It is more their overall function. Is a valve replacement going to change their outcome? Is it going to help give them better quality of life? Is it going to benefit them. And so we look at that very carefully. So it is not out of the question that there are some patients that our recommendation as a team might be, I don't think a valve replacement is appropriate, and we can have palliative care work with you to manage your symptoms. Sometimes we have to decide, do we do a temporary fix, like a balloon valvuloplasty, either to get them through the next phase of their testing or their dental clearance, or through another surgery or procedure prior to their TAVR. We can sometimes use it as a palliation, just to make them more comfortable, but it is a temporary fix. It does not, maybe gives them a couple of months to get through the other things they need to get through before actually having a valve replacement. So there are several options for these patients. So the therapy I want to just concentrate on next is this actual TAVR valve replacement. It's a transcatheter aortic valve replacement. It is meant to be performed kind of minimally invasive through the femoral artery. The TAVR valve goes inside the old valve, and so there is no valve removal. There's no surgical removal of the old valve. This just goes inside the new valve and kind of smushes the old valve out of the way and starts working. So this was developed for patients who, this was developed 20 years ago, for patients who had no option for surgery. They were either too old, too frail, had too many comorbidities, and so it was designed for inoperable patients and high-risk patients. Over time, it has proven to be an effective therapy, and so we now have indication for low risk, moderate risk, high, and inoperable risk patients. So I often get asked, how do you assess TAVR patients? How do you decide that they are a candidate for it? And like I said, this was meant for patients who otherwise don't have surgical options. They have other comorbidities. They would not, maybe do well during surgery. And so they do go through an extensive evaluation by a multidisciplinary structural heart team. So that is interventional cardiology. Currently, both Dr. Cook and Dr. Raffi do the procedure. Dr. Arnold and now Dr. Hart has joined our team. We have myself as the valve coordinator, the structural heart navigator. We have cath lab, anesthesia. We pull up all of their radiological studies, and we review everything in a structural heart team meeting. The slide that you see is just an example of a care flow path for a TAVR patient. So everything before that red circle is everything that they've gone through. The red circle is the day that you see them. So all of that has happened before they ever get there. We discuss them extensively during the meeting, and then everything after the circle is what they have to go through afterwards. So they typically will come and see me in the clinic. We do an intake evaluation, frailty assessments. They have consultations with both interventional cardiology and CT surgery. And then again, we discuss every case in the multidisciplinary structural heart team meeting. Some of those frailty assessments include this KCCQ-12 is a heart failure quality of life questionnaire. We do that on initial assessment at 1 month and 1 year, and they do a comparison. All of these are required also for TVT registry, so we keep track of all of this data. Their index of independence is just, can you feed yourself, dress yourself, toilet yourself, get in and out of bed yourself, those types of things. The essential frailty tool set, so they have to complete 5 chair rises. The goal is to do it in less than 15 seconds. We do a mini mental test with a clock draw test and recall of 3 words. We look at their hemoglobin for anemia and then their serum albumin for their overall nutrition, and that goes into a score. And then we also have them walk 5 meters, essentially 15 feet, 16 feet. And based on their height and gender, there is a time goal, less than 6 or 7 seconds. All of these go into like a frailty score and an assessment for their operation risk, which goes into kind of the overall evaluation. And then they have multiple other tests that they need to complete. So typically by the time they've come to see me, they have this echocardiogram that has identified their hemodynamics as severe AS. We sometimes have to recommend a transesophageal echocardiogram, depending. There are different types of AS. Maybe it's a low flow, low gradient, or paradoxical low flow, low gradient, that we just need to really investigate a little further to see what those, what that aortic valve looks like and what those gradients are. They all do have a heart catheterization, so we do a right and left heart catheterization and oftentimes try to cross the valve and take direct measurements of those gradients during the heart cath. This is for a few different reasons. One, right-sided heart cath for PA pressures, but we also want to know if they have any coronary artery disease, and then decide when do we intervene. If it can be done with a PCI, do we do that before or after the TAVR? So that all that gets taken into consideration. And then also if they have multivessel disease, that changes the conversation altogether. If they have multivessel disease, they are referred on to CT surgery, who can do the CABG and AVR at the same time. The CAT scan that you see is CT for TAVR planning is how you'll see it in bar. It does a non-contrast initially to get a calcium score of the valve, but then it is a contrasted study, essentially from like the chin to mid-thigh. And it's how we see the size of the vessels, the sizing of the valve, how we decide which size valve to go in. And that CAT scan not only gets read by our radiologist, but it also gets sent out to the 2 valve companies for measurements. We also do carotid ultrasound, pulmonary function tests. Those are very similar to what we do for pre-op surgical CABG and AVR patients. And then just again, the frailty scores, STS scores, lab studies, and then general physical exam. So these are just some examples of what we see on the 3-month CO report we get back from the valve company. So we look at the valve, the calcium on the valve, we look at the arch angle, we look at those femoral arteries to make sure they're big enough for the size of our catheter, and to look for any bends, twists, turns, anything that would hinder us from being able to advance the catheter for the valve replacement. So when would we not do a TAVR? Certainly if they had any sort of systemic infection, or we knew they had infective endocarditis, we are putting in a bioprosthetic artificial valve. We would not want, to have, infection on the valve. Aortic insufficiency without stenosis, the TAVR valve replacement is meant specifically for stenosis. There are some off-label uses for using a TAVR valve for aortic regurg, but that is it's a contraindication for how we're using it. Prohibitive annular size, it's interesting. We had 3 cases in a row a couple years ago that their native annular size was just too big for a valve. There was no valve that would actually sit in there. Medtronic has the largest valve at a 34 millimeter, and they sized out. The same can be true if it's too small. In that case, they may need to have a surgical valve replacement with aortic root enlargement. So that can happen. If their life expectancy is already less than 12 months, if they have, end-stage cancer, something like that, or severe dementia is also a contraindication, and then inability to be anticoagulated for whatever reason. So those would be some of the considerations for not performing the TAVR. TAVR procedural risk, even though it is a low-risk procedure, it does carry risk just like any other procedure. So anytime we enter the skin, risk of bleeding or infection. We are working in the femoral arteries and veins, so major vascular complications, including in the aorta or in the aortic root. The permanent pacemaker is a big risk, about 8 to 10% of patients, because of where we are manipulating in the area of the AVR is next to the AV node. And so the pressure on the AV node can potentially cause a heart block. So that is due to the anatomy and the need for potentially a permanent pacemaker. AFib, acute kidney injury from contrast use, and then stroke, we are working with a calcified stenotic valve. So stroke is about a 3 to 5% risk, heart attack, or death. Okay, so pre-op TAVR, what do you need to know if you are getting them ready in the morning when they come in for their procedure? This is what you need to know to get them ready. So before they ever see you, they have come to do their pre-op appointment. So we will tell them exactly date, time to be there, and then on the left you'll see all the instructions that we give them. So we treat them sort of like pre-op surgery patients. The first patient will arrive at 5 a.m. They go through the emergency department, registration comes out and registers them, and then they get them up to the CVU. However you guys do that, if you happen to have a tech that goes down or if somebody brings the patient up. And then the second patient, we have them arrive around 7:30, which is kind of tough because I know you're changing shift. but the first case ends up going, kind of quickly, and so we want to make sure that patient's ready to go by the time the first case is done. The night before, we have them shower with Hibiclens, nothing to eat or drink starting at midnight. We don't typically need to hold any medication unless it's an anticoagulant. So if they're on warfarin, Eliquis, Xarelto, all of those, then we will stop those about 3 days before. But otherwise, we pretty much let them take what they need to. Maybe a diabetic medication will stop. If they are on an anticoagulant, we will likely stop that and start a full dose aspirin on the days leading up to their procedure. We do not have them take their medications the morning of the procedure. Particularly their blood pressure medications. These patients can easily become hypotensive when during induction down in the procedure, and so we would rather them be running a little bit high and be able to manage their blood pressure down in the case, and then we can always catch them up on their medications when they come back up. So unlike the other surgical patients that have to have a beta blocker prior to going down, we prefer that our patients do not get those. The two medications that they will get is a full dose aspirin, and then they will get Plavix, 300 milligrams or 600 milligrams, depending. If they're already on Plavix for other reasons, then they'll get a 300 milligram dose, and if they are not on Plavix, then they will get 600 milligrams. So on that right-hand side, you can see we have a TAVR timeout procedure that we do a timeout twice during the actual TAVR procedure. So the part that we really need you to fill out is when was the Plavix given, and then when they come in, they'll also get a baseline EKG. And so if you could just write down what the EKG showed, that would be great. The rest of it we try to have filled out already. I try to come early that morning and fill out the annulus size and all of that. If for some reason it's not filled out and I'm not here, you could always get a hold of myself or Diana Weatherford, and we could tell you what those sizes are. Everything is scanned in, so some of those sizes comes from the Medtronic or the Edwards report that gets scanned in to the outside documents. But we'll have the rest of that. You'll also see the antibiotic. If they have a penicillin allergy, we'll use vancomycin, but otherwise we've been using Ancef and Unison both to cover strep, staph, and enterococcus. So I know we've had a lot of questions about why do we need both, but we're covering all of the bugs that could potentially cause endocarditis, especially because we're going through the groin access, and so enterococcus is a big concern. But this is the form that you'll fill out along with your surgical checklist and the other things. But all of the orders are preloaded, so you can just release orders, and everything you need to know will be in the order set for you. No need for any explanation on this slide. This is what we just went over, just about medication management prior to the TAVR procedure. So the TAVR prep is an important part of getting the patient ready for their procedure. They are transfemoral procedures. We do use both sides, so it's important to get the entirety of the groin area when you're shaving them. So think into the fold, across the peri area, making sure that all of that is nice and clean so that we can give it a good surgical scrub. We also prep them in case of an emergency sternotomy procedure, so you're going to prep them like you would both a CABG and a cath lab patient, but just making sure that you're getting all of the hair, making sure it's nice and clean. Oftentimes when they come downstairs, we're re-prepping them, so if we could do a thorough job up here, that would save us a step downstairs, and then it just helps infection prevention for them, and then actually also comfort as you're removing any tegaderm or tape from that area. So what happens with the patient when they get down to the operating room? The anesthesiology team, they will get all their lines, tubes, put the patient to sleep, get them intubated, do whatever they need to do. They typically will place the IJ line for our pacemaker. Cardiology comes and places the pacemaker. The patient gets prepped for the actual procedure. It does take both the interventional cardiologist and the CT surgeon at the table to place the valve. So they're at the table, the radiology tech is at the table, pass wires. Typically, interventional cardiology gains access to the femoral site that we're going to use. We will get some pre-hemodynamics with echo, whether that's transthoracic or TEE. And then we will start to pass the valve. They'll position the valve and get right where they think that it needs to be. We will use that pacemaker to to rapid pace the patient, reduce their cardiac output, and then deploy the valve. So we use two different kinds of valves. The Medtronic valve is a recapturable self-expanding valve. So typically we'll hold on to that one until about 80% deployed, and then we can check with the echocardiogram to make sure that the placement is good, make sure that there's no mitral leaflet impingement, make sure all of that looks okay before we finish deploying the valve. With the Edwards valve, it is a balloon expandable valve. So it's much like doing a balloon valvuloplasty, where we get it into place, we blow up a balloon, deploy the valve, and then the balloon comes out, and then we will reassess on echo. But we do rapid pace for the deployment of both of those, and so as soon as the valve is deployed, we stop pacing, recover the blood pressure, and then watch for any rhythm disturbance from being in that area. So if everything looks okay and we're happy with the way the echocardiogram looks, no perivalvular leak, no other interventions need to be done, then it's just a matter of closing the access, and then they'll be returning to the CVU. This just gives you a live picture. I tried to find some others of the actual deployment of the valve, but this gives you an idea of, this is the Medtronic valve. That is on the left, you'll see if you watch, it's being dialed up and then it flowers open. So you can see where it can be held onto at about 80%. And then to check that the probe you see at the top is the transesophageal echo probe. This is actually a valve-in-valve procedure. So the ring at the bottom, we're actually doing a valve inside. You can see the sternotomy wires. They've had that previous valve replacement. And then you have the temporary pacemaker, which is the two dots kind of floating around at the bottom. So if you watch on the left, you can see the valve actually all the way expand. And then the one on the right is the valve that's in place once it's all finished being deployed. Okay, so the patient is done downstairs. They send you the Volt message that says, gives you a summary of what's all been done, and then they say, okay, we're on our way. So then how do we recover the post-op TAVR patient? When the patient comes up from the OR, obviously your first task is always untangling all the lines and wires and tubes and getting everything settled. So as you're doing your normal setup, getting your art line leveled and zeroed and getting everything put in place, you'll want to make sure you know where your lines and tubes are going, so you know where your IV fluids are, where your antihypertensive or your pressors are going, and making sure you have a good understanding. Do an assessment with the team that's dropping the patient off of their groin access and their pulses, and then definitely want to look for any neuro changes. So they should be extubated down in the OR before they come up. They don't always have to be, but typically they will be. So they should be waking up. So just careful observation and neuro checks to make sure everything's okay, and if you find any deficits or any concerns, that you're notifying one of the providers so that we can take a look. You'll often see that their blood pressure is hypertensive and likely due to a hyperdynamic left ventricle. We did not have them take their antihypertensives that morning, and so we'll definitely need to get them caught up with that. So in the meantime, we'll use something like nitroglycerin IV or PRN labetalol or hydralazine in order to keep their blood pressure around 140 or below. And then as they're able to take in orals, definitely get them caught back up on their antihypertensives. Sometimes we have to hold their beta blocker depending on what we've seen down in the operating room. So we may hold that for the first 24 hours and just use other medications in the meantime. Monitoring their access sites and distal pulse monitoring. The large bore access site, we do use a 14 French or an 18 French sheath, and then we'll use a vascular access closure device, so either Manta or Perclose, or if we've done a femoral cut down, it'll be surgically closed. So watch for any hematoma, drainage, bleeding, and then watching for distal pulses, color, temperature. Hopefully that's been marked pre-op, and then also as you're passing off your assessment of the patient and the report of the patient, that you'll also look at that pulse together and make sure that everything's as it should be, and then just watching that. And then any arrhythmias, heart blocks, AFib, bradycardias on the monitor, and then let us know. Sometimes we'll leave that pacemaker in if we've seen anything down in the operating room, so you may have the pacemaker as backup. So when do we remove lines, tubes, what are we doing with our monitoring? So Our IJ neckline or the femoral vein line with or without a temporary pacemaker. While it's in, you do want to run KVO fluids through the side port. It is a venous line. Want to make sure it does not get clotted off. If it does not have a pacemaker in and you don't need that large bore access line for any other reason, if you've got good peripheral sites and you're coming off of any antihypertensive or oppressor, that can definitely be removed prior to the patient getting out of bed, or if they're experiencing some discomfort or bleeding from the line. There may be other reasons, and we can definitely get that taken out after a few hours. The arterial line, you'll just keep it if you're titrating the nitro off or any oppressors, or if you have any respiratory concerns that would require an ABG, you can certainly leave it in. There is an order under complete the following that is remove the arterial line when ambulating and hemodynamically stable. Typically the bed rest time is 8 hours, and so you can leave it in that whole time, but again, if you're off pressors, blood pressure is stable, then there's no concern about removing the arterial line early. You can always reach out to me or one of the docs and see if that's okay. But the order is in before the patient's getting up ready to ambulate. I've been asked this quite a lot about a Foley catheter. We did use them initially and ran into a lot of hematuria, urinary tract infections, just complications. So the general rule is no Foley catheter unless it's addressed with the provider for urinary retention or something like that. And then in that case, extremely careful placement of the Foley, especially the gentlemen that we've had, we've ended up on CBI, we've had a lot of bleeding. Just as a reminder, they have been loaded with 300 or 600 of Plavix aspirin. Even though the heparin has been reversed with protamine, they've had a lot of anticoagulation. So, and these are typically elderly gentlemen. So you can use a condom cath for the gentleman if able, or you can use a PureWick. Otherwise it's a urinal or a bedpan until they can get out of bed. So our bed rest times are ordered for 8 hours. That is because it is a large bore sheath that we're putting in, typically a 14 or an 18 French sheath. It does have a closure device, but we want to be very careful with access. Over time, our goal is to shorten that bed rest time, but for now, about 8 hours, but then out of bed. I know it gets later into the evening time, but we only have one day. Our goal is to discharge them on post-op day 1. So we really want to ascertain what we might need to do before that next day. Get orthostatic blood pressures, get them to the chair, see how they're feeling, see if they're dizzy, see if they're orthostatic. Do they need fluids? Do they need more physical therapy? Give a good assessment from the night shift. What will they need for the next day? We will order PT/OT for day 1 as well as an assessment by cardiac rehab, but these are typically older patients, and any time in bed just zaps their strength, as you know. So we don't want to go backwards as far as any endurance or stamina that they already have. So important to have them out of bed the day of the procedure, whether that is 6 o'clock at night or 8 or 10, whenever, but at least to get them out, get them up to go to the bathroom, just to do a set of orthostatics, let them stand up if it is very late into the night, at least get them moving a little bit so we can see what they can do on post-op day 1. So again, the morning of, an early morning for the patient, but out of bed for AM care, ambulation, get them in the hallway, do what you need to do that morning, and then back in bed by 7 a.m. for the echo tech. They all need a post-op day 1 echo per our requirements, and so those echo techs have agreed to come and see our patients first, and they have a very busy day. So making sure the patient is back in bed around 7 for them to come and do the echo is important, but then right back out of bed for breakfast. Unless there's some reason to have them linger in bed, that's okay, but otherwise, right back out of bed, making sure that they are up and ready for activity. And then before you're getting them out of bed, first thing in the morning is that site assessment. It is okay if you've already taken the IJ out on the day of procedure. You can take the dressing off of their neck, take the dressing off of their art line. Go ahead and leave those groin dressings on until post-op day 2. So if they go home, then they can take them off, like in the shower the next day or whatever. But we can instruct them to take those off, but go ahead and leave them. But everything else, any other dressings that you can take off of them, go ahead and do that. Typically their medication regimen won't change too much unless we've had to adjust blood pressure medications. The changes that we tell them ahead of time will happen. They need to be on dual antiplatelet therapy for the valve. So it is physician specific how they like to do it. You may see aspirin 325 daily for 1 month, and then we'll reduce it to 81 milligrams at their 1 month visit. They will be on Plavix 75 milligrams daily for 3 to 6 months. If they are already on an anticoagulant for other reasons, AFib, history of stroke, history of DVT, we may hold it for, let's say, a week, short time in favor of some dual antiplatelet, and then we'll restart it and typically drop the Plavix and just leave them on the aspirin and Eliquis, warfarin, Xarelto, whatever it is that they're on. They may be on triple therapy for a short time, and again, that is physician specific how they want to do that. For an aortic valve replacement, a bioprosthetic, there is no need for full anticoagulation. So you're not watching for INRs. They're not on lifetime anticoagulation. So we don't need that for the valve itself. But if they are on anticoagulation for any other reason, we can use that instead of the Plavix after a short time. But if not, then they'll be on aspirin and Plavix, and then there's no need for any Plavix after about 6 months unless they need it for a recent PCI. So like we said, all these patients have pre-op heart catheterization, so if they received a PCI prior to TAVR, the same rules apply for that PCI. They're on the Plavix for at least the year from when that was placed. And so that should be all in the discharge orders as well. Our goal is to discharge on day 1, so that's our benchmark. Certainly if patients need extra time, we can arrange either a day or 2 here in the CVU, or if they need to go to rehab. But essentially, we'd like to discharge them on day 1. Their discharge instructions: no heavy lifting, take it easy for the week, and then they will have a follow-up visit at 1 week. If that's with me or with Dr. Raffi or in the outer clinics, we'll look for groin assessments, making sure they're healing okay, answer any medication questions, see how their activity is going, and then typically release them for more activity. And then we will see them back in the valve clinic at 1 month and 1 year, and that's per TVT registry guidelines. So we will assess their valve with an echo, EKG, lab work. We'll repeat that heart failure quality of life KCCQ-12 questionnaire, make sure that they've gotten their permanent valve card in the mail, make sure that they've gotten connected with cardiac rehab, really at that 1 month appointments to see how they're doing and see kind of what their trajectory is, see if there's anything else that we need to help them with. And then at 1 year, the same thing. After that, it's recommendations for yearly echoes for surveillance of the bioprosthetic valve, and that can be done by primary care. It can be done by their primary cardiologist. And then, our hope and goal is that that valve will last them many, many years. But if for some reason they should have deterioration of the valve or any issues with the valve, they can be referred back to the valve clinic, and we will certainly have all their information, and then we can see what needs to be done. If you've made it this far, I'm super impressed. That is kind of a lengthy presentation, but certainly if you have any questions, any specific questions that come up with patients, if you have questions about how on a certain patient, how we decided that they were a candidate for a TAVR, I get all kinds of questions, and I know that sometimes when you're recovering them and you become a little bit skeptical, like, why did we do it? We have a full conversation about all of that in multidisciplinary TAVR meeting. So I'd be happy to talk to you about it. You would be welcome to come to a valve clinic or to a valve conference. We hold them on Tuesday nights, but certainly get a hold of me with any questions. So you can email me You can call me over in the valve clinic in the CVU office if I'm over here, Volt me, and then you can text me. I just prefer text just so I can answer when I'm not in with patients because my schedule is a little bit erratic, but I'd be happy to answer any questions or certainly hemodynamic questions or care of the patient. So thanks so much for making it this far, and thank you so much for taking care of our TAVR patients. You know, we obviously couldn't do it without all of your skill and your attention and your care for these patients. So thank you so much.